Good afternoon, ladies and gentlemen. It's a pleasure to welcome you with us to our second symposium on head and neck cancer and ethics. I'd like to acknowledge the traditional custodians of the lands on which myself and today's presenters and audience are located. I'd also like to pay respect to the elders, both past and present, and extend that respect to other Indigenous Australians present online. Before we kick off today's program, I've got a few housekeeping notes. Firstly, Seminar 1 is online and available for those of you who want to see it on the VCCC Alliance Open Learning site. Seminar 2 is today, and we're going to have a very nice afternoon. And we've got our third and final seminar in the series on the 19th of October. You can register for the final event via the VCCC website. And you can also browse other upcoming VCCC Alliance workshops and events. Please note that today's webinar is being recorded and will be made available to view on the VCCC Alliance Open Learning page once the final data is published. If you have questions for today's presenters or panel, you can do this via the Zoom Q&A function, which you can see highlighted. Please submit your questions through the presentation and we'll aim to answer your questions at the end of the session. I'd like to give my thanks to the team, Professor Claire Delaney from the University of Melbourne, who is leading this seminar series, Mr. Ben Dixon, who is Director of the Head and Neck Department at St Vincent's Hospital, Professor Hui Gan, Medical Oncologist and Clinical Research Lead at the Austin Health, Felicity McGee, Senior Speech Pathologist at Melbourne Health, Carly Fox, Consultant Plastic Surgeon, Peter MacCallum Cancer Centre, Laura Winter, Consumer Representative, and Rebecca Barnett, Head and Neck Nurse Coordinator at St Vincent's Hospital, Melbourne. Dr. Maury Wadder has given his apologies due to a clashing commitment today. So I think we could now move towards starting the session.
Thanks, David. Claire. Thank you, David. I'll just share my screen and we can get started. Okay. So thanks a lot. And thanks for joining us. This is the second, as David pointed out, of 3 seminars discussing ethically tough cases in head and neck cancer. And the key features of ethically tough cases are that all choices tend to be bad, all choices are legal, reasonable people will disagree about which choice is ethically preferable, there'll be different values at play, fundamental principles of bioethics may be in conflict, and yet a decision must be made. Something must be done. In the head and neck cancer context, other features are that there's often an urgency about the treatment decision, and the treatment itself will likely affect appearance, perhaps identity, and really important functions, eating, swallowing, breathing, talking, and both action or inaction are going to affect patients' outcome. So as David said, in the first seminar, we focused on decisions that are made in head and neck cancer. The fact that we can treat, but should we, was the question that we discussed. In this seminar, I'm going to shift the focus to the impact of ethically tough cases on clinicians. Distress, fatigue, and burnout are common terms and experiences in our current COVID-dominated working life. Moral distress is a particular type of distress, first introduced to describe nurses' experiences, but now much more widely used to describe experiences encountered by many other people across a range of professions and working conditions. So I'm going to begin by first defining what is meant by moral distress. And then, as we did in the first seminar, I'll present and we'll discuss a hypothetical case scenario to ground these definitions in clinical practice, specifically in the clinical area of head and neck cancer treatment, and invite both panel and audience comments. And in the final part of the seminar, I'd like to discuss briefly 4 approaches which some health workplaces offer to assist clinicians who experience moral distress, frustration, and tragedy in their everyday work. So I hope these insights and messages from today provide food for thought and motivate continued supportive conversations in your workplace. And I'm happy to be contacted about how these sorts of interventions might be set up in your own workplace following the talk. Jamerton first introduced or defined moral distress as it applied to nurses. And according to this first definition, which is a feeling of psychological distress arising because you're required to provide care or communicate to a patient in a way that you believe is not in a patient's best interests, or is the wrong thing to do. One current example of this at the moment is probably that we've all encountered is visitor restrictions, having to say no to family members who want to visit their relatives in situations where you think it would be appropriate for this family to have an exemption, but because of external constraints, you're unable to affect that outcome. Now, a feature of this definition of moral distress is that you've made a judgment about the right thing to do, but you're unable to follow through. But I think, though, that definition is a bit constraining in some ways, because I think sometimes you're not certain about of what the right thing to do is. And in this second example, it might be that you think you know what the right thing to do is, or you think this is the wrong thing, but you're not quite sure. And so, or you lack the level of assertiveness that's needed to put across that view, or you're powerless in some other way. Another type of moral distress is being morally uncertain, which is related to that second one. You're not sure of the right thing to do or say. Morally anxious is the feeling or the fear that something is going to happen, which is going to be wrong for the patient, or you're going to have to do the wrong thing. Morally conflicted is more a classic ethical dilemma, where you recognise that on the one hand you could do action A, and on the other hand you could do action B, and both have some merit and some downsides, and you have to weigh them up. And finally, the distress from epistemic or knowledge injustice, where you have a certain knowledge that you believe could contribute and assist in a situation, but you don't have a seat at the table, or your knowledge is not perceived as credible, or it's disregarded in some way. So this list has been written by Georgina Morley, and she's contributed to this literature quite recently. So it's worth following her up if you're interested in this. Now, I want to make this point before moving on, that experiencing moral distress is actually not a bad thing, because it actually demonstrates that you do care as a clinician and you take your role and your responsibility very seriously. And it's a sign of a compassionate and caring clinician. So it's not all bad, but as I explain in this next slide, there are some downsides. If you experience moral distress in any of those forms that Georgina Morley sets out, it can affect your sense of personal and professional integrity. It tends to lead to a feeling of something being lost, because you develop quite a strong sense of what your role is. And if you can't fulfill that role, there's a loss of professional integrity. And this can sort of chip away at your sense of duty and your role, your sense of what you need to do as part of your work. And it can lead to compassion fatigue, which is another term that's often in the literature, and which is just being exhausted and losing the ability to nurture and to show care. This makes it harder to continue to do the right thing, and can then lead to effects on your well-being, leading to anxiety, fatigue. And what we've heard a lot about recently is burnout and moral injury. Burnout refers to a syndrome of emotional exhaustion, depersonalisation, and reduced personal accomplishment, which really circles back to that loss of professional integrity. And moral injury is a term that has been used mostly in relation to soldiers coming back from having to be in the, committing actions that they felt was the wrong thing to do, but because of the circumstances, they had to keep on going with those actions. Sorry, I'm just having a bit of trouble with this screen. The other thing that can happen when moral distress is not addressed is that it can overwhelm the other really positive component of working in healthcare, which is compassion satisfaction, those positive feelings that result from helping others and finding meaning in your efforts. So this slide is a bit doom and gloom, but it's the idea of it is to portray that moral distress matters, and it's not something that should be ignored in your workplace and in your work. And the way that I'm suggesting it should be addressed, or one way to address it, is to take it seriously and to properly unpack the moral bit of it, so that you consider what is it that you think is wrong, because that feeling is the feeling of having to do something which you believe is wrong is a strong part of moral distress. So unpacking and discussing that moral bit helps to better understand the ethical aspects and complexity underpinning any stressful event, to better understand your feelings of distress, and to identify sources and drivers of the moral problem. So now I'm going to go on to the case we're going to discuss today, and to get your experiences and comments. I'm looking forward to hearing from the panel and from you. So Eugenia is 73 years old. She lives in the eastern suburbs with her husband, has 3 adult children. She moved to Australia 45 years ago from the Mediterranean, broadly. She's engaged in home duties and has a small but close and supportive social network. And she can speak English quite well, but her husband, Jim, answers for her and seems to be the one in charge of all the medical decision-making. Eugenia presents with she's been referred to the multidisciplinary meeting with a 3-centimetre indurated ulcer on her left buccal mucosa, as you can read there. And she's staged as having a squamous cell carcinoma. And the treatment recommendation is excision of her left buccal carcinoma with a marginal mandibulectomy, radial forearm free flap reconstruction, and ipsilateral neck dissection with likely adjuvant radiotherapy. So that maybe seems all sort of straightforward, but I'm just going to pause there and ask the panel to explain what this might mean for Eugenia. So I'm going to ask the panel to turn their cameras on. And if I can ask, well, anyone on the panel, what does this surgery mean physically and functionally for Eugenia? Is this a really major surgery? So we can just get an understanding. Maybe Ben could answer this one.
Sure, I will start. Well, yes, it is a major operation. It's a long operation. It takes its toll on the body. It's a long inpatient stay. There are major implications in terms, short term, in terms of airway and speech and swallowing. And so the first week is very tough. The operation itself is generally very long. It would be most of a day, usually, with a free flap reconstruction. Normally tolerated very well, though. So I'm sure if she's otherwise fairly well, she'd be able to tolerate such surgery.
Yeah.
So I would say we would class this as a major operation. Physically and functionally, the expectation would be over the medium to long term for her to be functioning very well. That is, eating and drinking normally or close to normally, speaking with a buccal and marginal mandibulectomy. I would expect speech to be largely unaffected. So I would expect a return to speech and a normal airway, and should be relatively pain-free. There will be some issues with oral cavity function, perhaps chewing, dentition, potentially some speech changes, but overall function would be very good long-term from our perspective. Obviously, the patient may have concerns with any of those issues, but I think we could, all of those things that are issues in the perioperative period really improve over time. Okay. I might leave it there. There's plenty more to talk about. But
yeah, no, that's really helpful. I'm interested in whether you would describe this as curative, if anyone wants to.
Yes, we would describe this as so. It's important to say that you've written surgery there, but this is surgery plus most likely radiation therapy afterwards. So surgery plus radiation is curative intent treatment. That doesn't mean it's 100% chance of cure, but we would be expecting more likely to cure than not in this scenario, assuming the full recommendation is completed, which is likely to include postoperative radiation as well.
Yeah, so it's a package.
Yeah.
Yeah. So, Laura, you're a patient well, you're not a patient anymore. You have been a patient, but what's your take on? Would you be feeling confident with that description, or I suppose that might not be the the right question, but what does that sort of explanation feel like for you?
For me as a patient, that would be overwhelming, but it would also make me feel hopeful that there is an outcome that is effectively me going on to live. And that's what I guess the aim is. And you come in, you get a diagnosis, all that is a lot to take in and a lot to process. Yeah. But ultimately, you have the opportunity to hit doing most of what you want to be doing. Yeah. And that's enjoying life. And I think that's all you can hope for. But it's a lot of information to wrap your mind around at that appointment.
Okay, so yeah, that's really interesting, and I'm going to move on because I want to get to the to some points, further points for discussion. Sorry, the point I want to start thinking about is, would it be ethically reasonable to refuse this treatment? And it goes to that idea of how curative this package is. So let me just move on and we'll open it up again. So the discussion with the whole team was very focused on cure, returning to all functions, and as Ben pointed out, some acknowledgement of the potential for mild speech and swallowing deficits. But she should return to everything that she was doing. But Eugenia's husband, Jim, has not been reassured about the likely impact of the surgery. He's concerned the treatment offered is too aggressive. He thinks it'll aggravate the cancer. He's really worried about the tracheostomy and the fact that Eugenia won't be able to cook and eat the same things. All along, Eugenia has said very little during these visits. And in the end, after many visits to the surgeon and discussions, Jim decides they'll go back to their own country for treatment. This, of course, was pre-COVID times where you could travel. And so I'm interested at this point in going to ask the audience to respond to the poll. If I can ask Cynthia to put the poll question up. There we go. So I'm asking you here what you think about whether this situation raises a type of moral distress where you think that you know the right thing to do, so you might tick that it's constrained moral distress. You're not sure whether you should intervene and try and stop Jim and Eugenia, whether or not you can. Whether you're just generally feeling morally anxious about this, whether you see it as a genuine dilemma, or whether in your position you might even have information here that you could contribute, but you're not really in a position to contribute. So I can't see the outcome of this, but I'm hoping a few people have voted. So Cynthia, if you move it to the next. Here we go. Everywhere. Perfect. So we've got different types of moral distress here. And I'm interested if you want to put something in the chat or in Q&A to explain why you chose what you did, or where you see the main point of ethical concern. And while you're doing that, I'll go back to the panel and let me just see. They were your choices. And just ask the panel here, or you can close that. I'll just close that over. Yep. Felicity, what do you think is ethically at stake here? If well, you might not answer that question, but if Eugenia doesn't have this surgery, or perhaps the second one, how much time and effort would you put in? Do you think enough's been done? You know, Jim has rung the surgeon 4 or 5 times. They've had 3 visits. Is that enough?
At this stage, Eugenia's had quite a few sessions with the one team. It might be time now to see whether we could actually engage a GP or someone different to try and make some inroads here. So if the core team's not getting through, then perhaps the GP, or asking if they would like to meet someone who has been through the surgery before, because it seems there's a little bit of a disconnect between what Jim is concerned about and what the long-term issues are going to be for Eugenia following the surgery.
Yeah, so you would try a few other avenues to ensure that you know, a bit more time in trying to convince or to inform
Yeah, it worries me that Jim's very fixated and concerned about the tracheostomy tube, which we'd be thinking for this type of presentation, a tracheostomy tube and a nasogastric tube would be a very temporary measure, somewhere in the order of 5 to 7 days would be expected.
Yeah. And would anyone interfere with Jim's approach and try getting Eugenia on her own?
Yes. in a nutshell, I guess, as part of our preoperative workup and with this sort of patient, I mean, my, number one priority is always to speak to the patient. If I've got to ask them medical questions, if I've got to do a background, all that sort of stuff, my first point of call is always the patient rather than their next of kin. So, we are in close contact with all of our patients who have been consented to this type of surgery. So, I'd be getting her on the phone, which, is hard if we often have patients who just put the phone on speaker and both of them are in the room all the time.
Right. Yeah.
That's really common.
Yeah.
But yeah, I'd for sure be trying to, see what her opinions were by herself. And I sort of echo what Felicity said as well, that, with the English being the second language, I'd hope that they had a GP that was, often you'll find with these people, of the same background, that they might have a close relationship with, that they might trust more.
Yeah. Yeah. So I'm hearing that you would try to make more of an effort and try some different strategies. And Carly, do you have, you mentioned earlier in speaking with you that you had a patient quite similar to this situation.
Yeah, definitely. I think it's an issue of informed consent initially, isn't it? Because you need to consent to have treatment, you need to fully consent to refuse it. And at the moment, we can't be sure that she's not being coerced or what's going on behind the scenes. So 100% I agree that we would need to get her answer with an interpreter specifically to work through all of that. And then just trying to really work through each issue and each thing that they're worried about, hitting that on the head and working through each one of those things individually, because what is ethically at stake, to answer question one, if she doesn't have the surgery, is it's really a decision between living for hopefully a long time or living for not very long, and that really needs to be nutted out to them.
Yeah. So in this case, the stakes are reasonably clear in that this surgery, there's not uncertainty about it. Whereas in some other situations, if you weren't so certain about the treatment and its effects, that would probably make this decision a little more difficult, or it would change how much effort you put in, perhaps.
Yeah, definitely. If there was no, she was very old and very comorbid and there was no sort of clear-cut operation that you were going to do and you weren't going to get clear margins, all of that, you would certainly think really hard about offering it to them, and the lines are a lot more blurry. Patients are allowed to say no to having operations too, by all means. We can't presume to know all their cultural decision-making, all of that, but the case here is pretty cut and dry for us to offer them. Yeah.
And David, are there some questions in the chat or comments that you want to refer to? Oops, you're on mute, David.
I think that there's a certain point in a consultation with a family and with a patient where the team has to ask, are they the best people for this family? And if you're not the best people for the family and you're not achieving anything in your consultations with them, should you in fact hand over to another team? Send them to the Western, send them to the St Vincent, send them to the Royal Melbourne, to another centre where there'll be different people looking after them and they may have more faith in a different team. Because the price of making the wrong decision is a very difficult one.
Yeah. And I mean, well, that's right. And I'm interested in the audience definitely picked a range of different types of moral distress and distress that they would feel about this family. And in some senses, there are some actions still to work on.
We have got a comment in the chat room, and I'd like to hand over to Dr. C.N. Fewer, who's asked a question about the ability to decide. Cian, are you able to open up your microphone and speak?
I'm not sure whether they can.
So Cian has said.
Looks like I might be able to.
Oh, there you go.
Have. Okay, over to you, Cian.
Sorry, I was just on the phone as you were speaking. Could you repeat the question, David? I'm so sorry.
You've made a comment. You're concerned that Eugenia hasn't actually been able to decide what she wants. I believe patients have the right to choose their path, but I'm not sure Eugenia is actually the one making the decision, is the comment you made.
Yes, so I agree entirely with what Carly said, that you know, we can't presume to know what's important for patients, and we kind of make ethical judgments ourselves as people get older. We wouldn't be surprised if they said they didn't want treatment when they're very young. We feel it's unjust if they come up with the decision that they don't want treatment. So I think the main issue is really the husband, and the worry that even if we do get Eugenia by herself, she will still feel compelled to answer something that she thinks her husband will agree to. So sometimes even when you get her alone, it's still going to be a very difficult judgment call as to whether she's making a decision that she actually wants, or she's trying to please what she knows her husband is keen for her to pursue.
Yeah, I think that's a really good point to make, that in considering how you can respond to a situation like this, there's usually pros and cons of each response. So even if you manage to get the Eugenia on her own, it's hard to separate her from her family. And so it's that, you know, the benefits of speaking with her by herself sound like they might address the fact that she hasn't had a chance to speak, but there may be other factors going on. Before I move on, Laura, did you have any other comments, just again as the patient perspective?
No, but I agree that I don't think speaking to her on her own would help. I think she's going to be wanting to please her husband. So I agree with the GP avenue or something like that. I don't think they sound like a couple that would come in individually or split the team, I guess. So yeah, I think that's right. It's more complex than it seems. So when talking about when I introduced earlier this idea of taking moral distress and concerns seriously, there are a few ways you can approach it, and already these ethical principles have been referred to. The standard ideas that underpin our practice is to respect the patient's autonomy and preferences and choices that they make. But I think this case of Eugenia and Jim raises the question of whether you respect the family autonomy as well as Eugenia's individual autonomy. So some of the questions when you start thinking about, well, what does it mean to respect someone's individual autonomy, and is that even appropriate in this situation? And you may fall somewhere between, well, it's not really up to me to interfere with this couple's communication style and the way they end up making choices. Or you might be at the other end of the spectrum, if you like, and be thinking that you need to organise a time to speak with Eugenia on her own, or you as has been raised, sending her to a GP or some other team, as David had suggested. Carly raised the issue of informed consent, and I think that's a very relevant one in thinking about how much information Eugenia needs, plus in what way can it be presented, and in a staged way, such that you maximise her chance of understanding, organising other people to speak with her, and ensuring as much as you can
that her decision is voluntary and she's not being coerced. And then the other part of if you bring in these ethical principles, is just being really clear about the benefits, the burdens of the treatment, which is where we began in describing, what is the curative, how sure are we and certain that it is curative, and whether or not that certainty will influence how much persuasion and energy you put into that versus giving the patient the chance to decide. So falling back on those principles can help unpack that concern about, have I done enough? Should I be saying more and spending more time? Another way of unpacking this particular case is to think about your role as a clinician. And this is an old paper, but I find it quite useful in distinguishing between different types of communication. And adopting a paternalistic approach means, telling Eugenia that what you think needs to be done, and that's my opinion, and take that. No one so far has suggested that would be enough. The informative model is to give Eugenia and Jim all the information they need, the pros and cons of having or refusing, and letting them decide. The interpretive approach is to spend more time interpreting what it means for Eugenia if she were to choose to have the treatment package versus not, and how she might think about that. And the deliberative model is similar, but goes more into probing values, fears, hopes, and helps of Eugenia and Jim, and tries to assist them in weighing up those values. So that's another way in this case of taking the moral bit seriously. And you end up doing what we've started to do anyway, which is to come up with possible responses that you could put in place. So option one is to give information and allow Eugenia and Jim to make up their own mind in their own way. And there are some good outcomes in that you're not interfering with the way they operate, but there are some downsides. It may not be enough, and if you pushed a little bit more, that may be better. The second option is to refer Eugenia and keep trying, putting more energy in, and there are some costs to doing that. And I'm interested if there are some third options, or whether the panel and the audience has any views about. I've just put two options there, but any other options or any pros and cons that we haven't discussed in cases like this that you've found in your experience to be useful. So I'm just going to ask again the panel to comment on those options. I might even keep the screen shared while we do that. Rebecca, you've probably spent quite a bit of time with, families and people in these situations. Is there any other options or pros and cons that we haven't discussed here?
I think, option three could be sort of halfway between, which I guess we've touched on already, talking about the GP. I mean, looking at that previous slide on those four, types, I sort of lean towards probably the last one where, and it's probably been made a good point by other people on the panel that, you probably can't separate them and, speak with Eugenia alone, and you need to really concentrate on, talking about what the exact issues they have with the surgery and breaking them down and, explaining that, the tracheostomy is temporary, the nasogastric's temporary, and what it looks like for the future. So, I think there is an option 3, and I think it is a halfway between.
Yeah, between the two extremes, or well, they're not extremes, but the two approaches. And there's a couple of comments in the chat, David, if you want to bring them or refer to those. And you're on mute.
So S. Jones is suggesting we apply a cultural lens and suggest investing in exploration, religious, spiritual member being invited to support a conversation. So bring in a third party of the family's choosing that may be able to help.
Yeah, well, that's right. We introduced the culture. I think it's a good point to make, because we introduced the cultural lens at the beginning, suggesting that Eugenia, came not from Australia and will bring in her particular cultural values, and whether we always circle back to that and treat it as and give it a bit of time is an interesting point to make. Any comments from the panel about that? And I think I noticed that there was another in the questions. There was, what about the 3 adult children as another option from Jill Sewell, which hasn't been raised yet, but I imagine that that's something that you might also investigate.
There's actually another comment there about involving a psychologist or a social worker to help with some of those family discussions, and that would be something that would also fit well into option 3 if Eugenie and Jim were to agree to that. Yeah,
I'm interested if people see any downsides to all of this, this amount of effort with Jim and Eugenia. I'm not suggesting it's inappropriate, but there's always pros and cons with each option.
I think we also need to explore what their expectations are in inverted commas, their own country, knowing that they've been here for 45 years. Yeah. I'd be hopeful they'd feel a little more affinity with the local healthcare, but just exploring exactly why they think or what they think will be different if they do go somewhere else. It's probably just to try and escape rather than to tackle reality, I would have thought.
Yeah, that's a really interesting point. And it goes to that deliberative model, that exploring what it is they're hoping for and what it is that they're fearing here, which is, one of those, one approach that you can take, but I think that's a good example of the deliberative one.
Yeah. And I think that gives us another avenue to explain why we're doing what we're doing, and it wouldn't be any different overseas. There's not different protocols necessarily. Yeah. And there's a possibility they would have inferior treatment or half the treatment and be in a bit of a pickle, which is often the circumstance that we see. The other point I wanted to make, and I'm sure Beck and Felicity will be able to back this up, is we normally do find a way in with these patients. And we do sort of, it's almost a 360-degree approach with who else can we get in terms of other people within their community that can help with the decision-making, and they often volunteer that, particularly with children, especially if their children have grown up locally. And it's very common we see the situation, and it's very rare that we can't get through it. Would you agree with that, Beck?
Yeah, absolutely. I mean, it's definitely not the first case we would have seen that was like this, and 9 times out of 10 you manage to find a way around and get the right people involved to help this patient make that decision. I think the 3 adult children is always a good way about it. We're always speaking with non-English speaking family members to help them make decisions, and it is a whole team and a whole community approach.
Yeah. There's a couple of wonderful comments. I hope you don't mind me, David.
No, please do.
straight to them. John's talked about a case where the fear was, in fact, that the Sicilian mafia would be onto the patient if they saw the scar or something along those lines, and they managed to convince this lady. And but I'd like to go to Cheryl's point. I acknowledge Jill Sewell's point here that the children is a way that may help with cultural and family interpretation. I think that's a really good point to make. But I'm going to go to Laura and then move on, because Cheryl Martin makes the point here about the inherent power differential between patients and clinicians, and whether patients realise, you know, they can speak with other members of the team, or, you know, perhaps one of the blocks here is that although Jim is sort of suggesting he has had multiple team meetings or meetings with the surgeon, there might still be some unease with how they can communicate their fears. So from a patient perspective, Laura, what do you think of it?
I remember my nations, and there's so many people at that initial point, and they're overwhelmed with information. But I know it was said to me in that meeting at the start and again at the end to phone or email, and I guess that's part of Beck's role as well. And after that diagnosis, the head is spinning, and I was emailing the nursing coordinator at all hours with anything that popped into my head, and that was my way to get the answers, because you don't think of the questions until well after that meeting, and then different parts of that come back to you at random times. So I don't think you're expected to take it all in, and that's why it's helpful to have someone else attend the appointment, because you both take in different parts. Unfortunately, Jim here is just terrified of the whole prognosis, and his fear possibly is making her unable to voice what she would like.
No, that's really interesting to sort of take that and realise that it needs to, the conversations need to happen over time. I'm going to move on to the final phase that 18 months later, Eugenia's son has an appointment. Eugenia has persistent disease. The tumour has fungated through her cheek. She's losing weight. She's experiencing severe pain, impacting her communication, and she's unable to take any oral diet or fluids. And he asks, can anything be done? So the team, especially the lead surgeon, is very distressed by the outcome, and you know, is consumed by this idea of, if only she had the operation when she presented, the outcome would have been so much better. And here, Cynthia, can you just pop up the second poll question, because I'm interested in people's view about this. So if this type of experience with Eugenia and her family, do you believe that something like that definitely requires, if you were involved in it, follow-up support and debriefing? Or do you tend to think, well, this is part of the job and staff are already trained to deal with this, we did our best, or in a not sure camp? So if you can have a vote there, and let's share that, Cynthia, and see, I'm not giving you much time, but see what people have chosen. I can't see the results there. Oh, there we are. Okay, so we've got the majority of those who voted saying it definitely requires some follow-up. So thank you. Thanks, Cynthia. I'll close that over. And so, yeah, how does this situation, I'm interested in the panel's comments here. And again, if anyone wants to sort of explain their responses a bit more in the chat. But on one level, this is common, I heard you saying. And then on another level, this is distressing. So does anyone want to comment on that? What do you do about that? What sort of debrief and support do you have available to you, and what helps?
I think for me as an individual clinician, I would, it is really distressing, and I would be thinking to myself at the time, were these patients adequately informed? Did I give them all the information they needed? It goes back to that informed consent thing. Did I give them every bit of information that was important to them that I could have, including what would happen, talking them through and walking them through what would happen if they refuse treatment, because this is what happens and it's really ugly. And once you've done all of that, including, I think, the point about getting a family members in, because they can also corroborate, yes, this is how my parents are, and this is in keeping with how my mum makes her decisions, etc. Making sure all of those boxes were ticked to finally end up at that decision. But 18 months down the track, if you didn't write it all down and you don't remember if that's what you did, and it definitely becomes very distressing. So you try and stamp that stuff out as much as you can at the time when you're talking through them and counselling, and we're all told to document everything to make sure the boxes are ticked, but it doesn't really make it any better to have to see someone like that and tell them, no, there's nothing we can do. That's it. Refer them to PAL care. It's tricky. You can try and alleviate it as much as you can by ticking all of those boxes, but it's still hard.
And I think at this stage, what I've been talking about the most has been the ethics debrief idea, which is that in situations like this, even though the outcome is a bad one, and that you can feel bad and look back and feel distressed about whether or not you've done all the things you possibly could. The suggestions that I've been making all the way through are the importance of doing something like this, and having a facilitated discussion about, tell me what in looking back, could you have done something different? So that, and where do you think the main wrong occurred? And so that it helps just unpack the feeling, so that you don't take the feeling home and it doesn't accumulate, that you've had a chance to work out with colleagues and with some support to figure out, if something did go wrong, what would you do differently next time, which can be immensely helpful. Because we're getting near the end of time, I won't go through each of these in any great detail, but just to distinguish between them here. Other options available that you may well have experienced are psychological first aid, which in response to this case would mean just checking in to find out whether you're feeling okay and have you got the supports that you need. So it doesn't go over the case, it's just there to check that you're okay. Critical incident stress debriefs or hot debriefs, you might have, which are similar, tend to occur in a team setting where you go over the case, you check in on the emotional reactions, and you also figure out, okay, how can we work together as a team to address these sort of issues in the future. The ethics debrief is what we've done today, which is talk more about why, what is wrong about not speaking enough to Eugenia. Should you get her on her own? Should you accept that this is the way this family operates? How much effort should you put in? And then the final one is clinical supervision, which you may also have experienced, and that's a regular forum of facilitated discussions where you build a sense of trust, and you're facilitated to reflect on your work and on, these sort of situations, and, work out again why things have gone wrong or why they've gone well, how they've affected you and how you can move forward. So that's a sort of regular supervision session to debrief. So any final comments and any chat comments and questions, because I know we're just about out of time.
Yes, thank you, Claire. David Rowe, an ear, nose and throat surgeon at Austin and Royal Melbourne, has made a comment.
Mm-hmm.
And David, if you would like to speak, you're welcome. Otherwise, I'll repeat your comment. So we believe that treatment in head and neck surgery has the power to heal and save lives. Sometimes even our best treatments fail. No one can predict the future outcomes with patients in these situations. Our interactions with patients and family in these situations are ones that the patient and family will remember.
Yeah.
Yes, I don't know if you can hear me, Prof, but
Yes,
yeah, we can.
hear you, David.
sorry, I beg your pardon. I just thought a lot of the conversations and comments made by people were fantastic and really did cut to the core of the issue. But I think when I've reflected back on my interactions with patients, and particularly ones that have been in difficult situations where either despite our best efforts, a bad outcome has happened ultimately because of the cancer or because of patients that have decided to withdraw from treatment. On reflection of those situations, it's how not just the doctors and surgeons, but also the allied health staff and everyone involved. Often, it's the nurse practitioners or the nurse coordinators that come to the fore are the ones that the patients remember, and it's our interactions with them at that very sensitive and difficult time that I think has the most profound effect on them. And that's something I think we should all remember.
Yeah, I think that's a great point to make. And the final comment too, that Teresa has made is quite similar, that, if we've exhausted all those possible avenues, and I'm going to finish on this final slide. I'm having a bit of trouble with my slides here, sorry. There we go. This is the final one, because I think it makes the same point, that in unpacking and having these sort of conversations, you end up being, one of these three things. You might still feel some regret and sorrow about what happened to Eugenia, but you have a better understanding of why it happened that way. Or you might, end up thinking, well, the decision was ethically okay for what they did, but maybe our communication could have been improved. There was some aspect of it. And what I'm hearing, I'm hearing the first one the most, but the third one is you may end up thinking, well, look, what happened with Eugenia was the wrong thing, and next time I'm going to put more effort into, wherever you decide it needs it. So it can be really useful for you to go from feelings of distress through to some actions that you can take, and that's an outcome that is a useful one. So I'll end it there and hand over to David. I think we're out of time.
Thank you very much to Claire Delaney from the University of Melbourne and all of our panellists from the VCCC Alliance. I think we've had an excellent discussion about challenging situations for clinicians and how clinicians are able to deal with difficult problems. The webinar has been recorded and will be available on the VCCC Alliance Open Learning page once the data has been published. Our next meeting will be on the 19th of October, and the topic is the ethics of progress in head and neck cancer. And again, to all of our presenters, panelists, to all those that raised issues in the chat, and all of those that spoke, thank you very much for joining us.
Thanks, David. Thanks, everyone.